Good morning. My name is Joshua Lyons, and I want to thank the SAGES 2024 committee for giving me the opportunity to discuss our data. Our presentation today is initial experience and outcomes of per-oral pyloromyotomy for the treatment of refractory gastroparesis. These are our disclosures. So gastroparesis is defined as delayed gastric emptying in the absence of any mechanical obstruction. This can then lead to a number of symptoms, including nausea, emesis, gas bloat, early satiety, and pain. There are a few known etiologies that can lead to gastroparesis, including diabetes, especially type 1, post-surgical, mainly from any foregut surgery, some neurologic disorders, or idiopathic. There are a wide range of available treatment options, including lifestyle modifications such as dietary changes like small, frequent meals, avoiding carbonated beverages, chewing food thoroughly. There are a variety of prokinetic agents that are used in gastroparesis, although their effectiveness can vary over time and, of course, also come with their own side effect profiles. And then finally, there are invasive interventions such as gastric pacing, laparoscopic pyloroplasty, and the per-oral pyloromyotomy, also known as a GPOM, or as I'll refer to it, as a POP. So this was a retrospective case series of all patients who underwent a POP at a single institution over a 6-year period. We prefer to make the mucosotomy on the lesser curve of the stomach as seen here, make a short tunnel, shorter than is illustrated here, divide the pyloric muscle in its entirety until complete fiber separation is seen, and then close the mucosotomy with multiple endoscopic clips. Data was collected from the electronic medical record, including demographic information, preoperative symptoms, workup, postoperative complications, and finally, symptom recurrence or the need for additional treatments after a POP. So 56 patients were included in the study. There was a 1.8 to 1 female to male ratio. The average age was 56, with nausea being the most common presenting symptom. Average symptom duration was 1 to 3 years. 38% of patients had a previous endoscopic therapy, that being either a pyloric dilation or pyloric Botox injection, and 16% had multiple endoscopic procedures. For the etiologies in our series, 50% was post-surgical, with esophagectomy and fundoplication being the most common past surgery. Diabetes accounted for 23%, and the rest were idiopathic. As far as our results, there was one postoperative complication, which was an NSTEMI, but the patient made a full recovery after this. Persistent nausea was the most common symptom at follow-up, but this improved at the 6-month mark. 27% of the patients developed symptom recurrence at some point, with the average time to recurrent symptoms being approximately 11 months. But most of those patients were managed medically, and only 11% of patients had the need to undergo a repeat endoscopic or surgical intervention. When the outcomes were studied based on the patient's etiology, patients with post-surgical or diabetic gastroparesis were more likely to develop recurrent symptoms as opposed to idiopathic, but the rates of needing further interventions were similar between the groups. So in conclusion, in our study, per-oral pyloromyotomy led to persistent symptom resolution in just under 75% of patients. There were very minimal associated complications. And if symptoms do recur, the majority of patients can be managed medically, with only a small percentage requiring further endoscopic or surgical treatments. And then finally, for those in the audience who don't perform this procedure, this is the endoscopic view of the pyloric muscle immediately prior to division. Thank you, and I'd be happy to take any questions.